Um, okay. I think if everyone is ready, I think we can begin now, and then maybe the rest can join us along the way. Is that okay? Hello. Aditya, could you just confirm that you can hear me and everyone can hear me?
Yes, sir. You're audible.
We can hear you.
Okay. So we can start, and then the rest will join us along the way. Yeah. Okay. So good day, good evening, and good morning to everyone joining us from different parts of the world. My name is Dr. Ian Sote, and I'm joining you today from Nairobi, Kenya. I serve as the committee member with the TORG Global Education and Training Committee. On behalf of TORG and the TORG Global Education and Training Committee, I am delighted to welcome you to today's global webinar. So we are pleased to have a truly multidisciplinary audience with us today. So we have surgeons, anesthesia providers, nurses, surgical technologists, perfusionists, educators, researchers, students, and healthcare leaders. We are currently joined by participants from multiple countries across different time zones, and we sincerely appreciate your time and commitment to continuous learning. Whether you're joining us from Africa, Europe, Asia, the Middle East, the Americas, or elsewhere, you're very welcome. Good morning to those joining us early in the day, good afternoon to those in the middle of your day, and good evening to those of us joining later. We are grateful to have you all with us. We strongly encourage active participation throughout the session. So do feel free to use the chat box to introduce yourself by sharing your name, your professional title, and country. Also, post your questions and comments at any time during the presentations. Our moderation team will be actively monitoring the chat and will bring your questions forward during the discussion segment. So for those joining our TORG session for the first time, the Operating Room Global, TORG, is a multidisciplinary professional platform representing over 260,000 surgical and perioperative professionals across more than 110 countries, making it the largest global network of operating room professionals worldwide. TORG brings together 42 healthcare disciplines and specialties currently and operates as a not-for-profit and non-governmental organization founded in Nigeria in August 2015. Today, TORG has over 20 active chapters globally, including representation across 31 African countries. Our mission is to advance surgical and perioperative care through education, research, advocacy, innovation, and capacity building, with a strong focus on safety, equity, and system strengthening. TORG is an internationally accredited continuing professional development provider recognized by the CPD Group, underscoring the quality and global relevance of our educational activities, and is supported by its academic and innovation arm, the Operating Room Global Center for Education, Research and Innovation, incorporated in Ireland, which leads our global agenda in education, research, innovation, and partnerships. Our affiliated journal, the Operating Room Global Journal, is an open access, peer-reviewed international journal inaugurated in May 2025, providing a platform for high-quality evidence that informs practice and policy worldwide. TORG is also proud to host its own institutional review board, TORG-IRB, which is officially registered with the US Office for Human Research Protections, reinforcing our commitment to ethical, responsible, and globally credible research. TORG is driven by a volunteer-led leadership model powered by passionate professionals who contribute their time, expertise, and vision to strengthen global surgical care. We are actively engaged with global alliances, including the G4 Alliance, Intersurgeon, and are listed with the Union of International Associations and the Global Civil Society Database, reflecting our global accountability and reach. With that short introduction, I'd like to welcome my colleague to introduce our guest speaker. Thank you. Aditya, you can take over.
Yes. Thank you very much, Dr. Naigringo, for the warm opening and for setting the tone for today's session. A warm welcome to everyone for joining us from different parts of the world. My name is Aditya Sachin Patil, and I am a member of the TORG Global Education and Training Committee. So it is truly an honor to be here and to be introduced our distinguished speaker for this important webinar. So today's session is a part of 2026 Global Education Webinar Series, and our focus is on the carbon footprint of the operating room, global strategies for sustainable energy. So this topic plays a crucial role in the future of perioperative practice, environmental sustainability, and global health. And we are privileged to have a highly accomplished expert guiding us through it. So it is my honor to introduce Dr. Nikki Washington, Doctor of Nursing Practice with a Master of Business Administration and Healthcare Management, a registered nurse, a certified perioperative nurse, and a certified surgical service manager. Dr. Washington currently serves as the Director of the Surgical Services at Joseph Hospital Medical Center in Stockton, California, where she is responsible for ensuring the financial sustainability and long-term viability of perioperative services. She is widely recognized as transformational leader, a leader committed to advancing leadership development and equipping perioperative professionals with the tools which is needed for the success in today's complex and surgical environment. Her impact extends far beyond the hospital walls. She actively contributes to community leadership by delivering educational presentation to underserved population and monitoring emerging healthcare professionals. Her leadership has earned her multiple organization accolades, including recognition by the Marquis, who's topped the healthcare professionals for their dedication, achievements, and innovative contributions to perioperative nursing. Dr. Washington has played a pivotal role in handwiring evidence-based policies and procedures throughout the perioperative and procedural services, using an interdisciplinary approach to strengthen quality outcomes and reduce patient safety risk. So, as a dedicated member of the Association of the Perioperative Registration Nurses Board of Directors, she brings strategic vision, financial stewardship, and a proven record of effective outcomes to national conversation on the surgical services excellence. As the heart of a professional journey, Dr. Washington draws her greatest inspiration from her family, her children aged 35, 30, and 13, and her cherished grandchildren aged 11, 9, and 5. She attributes her strength and resilience to the favor of the Most High, and she continues to view her family as a guiding purposing and enduring reason why. And with that, it is my absolute honor to welcome Dr. Nikki Washington to begin with the presentation. Thank you.
Thank you so much. I'm going to have to live up to that wonderful introduction. Today, I am going to bear with me. I'm going to share my screen with you all. I'm not going to be able to see you on camera. So let me do this. I'm going to try to figure this out. Share my screen. Let me do it this way. I'm normally at work when I do this. Well, I have two screens. And so I'm doing it off of one screen. So I'm going to see how to do this. Let's see. How many of you are familiar with Menti? Can you see my screen? Can each of you see the presentation? Thumbs up, yes, no? Okay, all right. How many of you are familiar with Mentimeter? If not, it is an interactive way and method to join and be interactive in presentations. So if you don't mind, I don't have the QR code, but the website is there. It is menti.com. And the code that you would type in is 1536-6753. If you would be so gracious to download that, That way everyone can join in, and it can be very interactive. I just want to thank everyone for joining. It's amazing to hear how multidisciplinary the audience is. I love it. I started off as a surgical tech and advanced the ladder through nursing, but I'm happy. I'm always happy when I hear that my surgical techs are in attendance. They are a very, very intricate part of the team, as well as everyone else. So those of you who have downloaded the menti.com and put in the code, I want you to answer this question for me. What sustainable methods does your organization have in place? And this is regards to the carbon footprint of sustaining green healthcare systems, especially in the operating room. Okay, I don't see any responses coming in. But what I am going to do is go ahead and get started. And maybe on the next slide, it will come through. Okay, so today I'm going to discuss the environmental factors and footprint of operating rooms and global strategies to make surgery more sustainable. I do not have any conflict of interest, and my overviews will be background and significance. Trying to center this. Waste and energy consumption, global impact and financial implications, as well as policy development, which is very important and monumental in the success of anything sustainable. I don't like this slide. Okay, here we go. Current practices. Does this screen look familiar to any of you all? So this is common waste that we see in healthcare facilities. Operating rooms are the most resource intensive environments in the hospital. Not only do they contribute financially in a positive aspect for the organizations, it can also have a flip side because of all of the waste. Waste is often measured by pounds. And so for organizations, when they have to take it to landfills, it's weighed, and that comes with a hefty cost. A lot of the waste is not necessarily used waste, but unused waste. And so it makes it very consumptuous for the organizations to have to pay for items that were no longer truly used, but they have to pay for that. And it adds to the waste, which also emits into the environment. So it's not just waste as we look at it in the operating room, it's also waste that goes into the environment and the environmental effects that it has on our patients, our community, and our populations. So I just wanted to show this. This is a picture of a landfill, okay, with medical waste. It's all types of waste. But this just gives you an idea of the abundance of the amount of products that goes into the environment, how many of them are medical waste environment, and how we as healthcare providers contribute to that, and how we can help curtail that. So healthcare contributes to about 4 to 6% of global CO2 emissions. Operating rooms generate about 20 to 30% of hospital waste. Now, I just mentioned a moment ago about unused waste. Unused waste contributes to products that we open and don't use. When we think we may need something, sometimes physicians may request that certain products are on their table or supplies are on their table as a just to in the event they need. when in actuality, the product was not used. And so anything that is open and not used, again, it adds to the cost of the waste. And how can we be good stewards in the operating room to ensure we're not opening an abundance of waste? When you think about the CO2 emissions, there's a lot that goes into that as well. And I'll delve a little bit deeper into that in my presentation. But we think about the anesthetic gases with the scavenger systems that some healthcare organizations have to capture some of the anesthetic gas waste. And then also the surgical plume in the environment, the waste and the byproducts of that and how it emits into the atmosphere. So surgical plume emits a certain amount of CO2, as do laparoscopic procedures. As we know with laparoscopic procedures, the abdomen or the abdominal cavity is filled with CO2. So what happens with that CO2 when too much of it is used in the patient? Are there guidelines or safeguards that your organization has in place to say how much is enough for the patient? Because we know each patient is going to be different. You know, each patient anatomy is different. Each patient is going to present different. And so always going to the low flow, high flow of 12 or 15 first straight off may not be so ideal because it's, again, it's emitting the CO2 into the patient. They absorb the CO2 and it also is dispersed back into the environment when the ports are removed or the ports are taken or opened to emit some of the plume. And again, we'll talk a little bit more about surgical plume. Hopefully your organizations have methods in place to like smoke evacuation systems to be able to evacuate a lot of the plume and the byproducts. A big thing we want to think about is sustainability versus practical. You know, what's in practice? Does it really work? Is it truly more cost effective to use reusable items? Or is it more cost effective to recycle? Which one is it? It just depends on the outlook and the organization. And if you have um, a mixed method, are you totally green? Or are you some things are green or carbon footprint, and then some things are still reusable? It just depends on your organization. There's no true one fit for all. It's what truly works for your organization. Now, balancing infection control and sustainability is a big topic also. We think about the infection control and we think about cost savings when you're recycling, but what about the cleanliness of it, the sterilization method? What are the IFUs? Is it one-time use that we're recycling or reusing? Are we working outside of the IFUs because we are sterilizing it anyway or reusing it anyway? I think organizations have to take a real deep delve and guide and look at that because I think about the blood pressure cuffs and I think about the STDs. Some of the blood pressure cuffs in organizations are, and I can speak for my organization, we go back and forth between disposable and reusable, and where we wipe those down. But when you look at the overall picture, cost is going to always be a contributing factor. But in the long run, what cost is sustainable? Is it the immediate cost or is it the long-term cost that not only affects the now, but the future sustainability? Regulatory requirements for disposables, again, it speaks about the IFUs. I know Joint Commission is real big on IFUs and they want to see the IFUs when they come and do their sites. One of the things I will always stick in my mind are the little Christmas trees for the O2. We were not throwing those out; we were wiping those down. However, it was a recommendation by the Joint Commission that we got the disposable ones because the ones that we had, the little green ones, did not have IFUs attached to those. And so if you don't have IFUs attached to those, how do you know if you are truly disinfecting it correctly? And if you don't know that, what you're doing is placing the next patient at jeopardy, as well as the healthcare professionals. So one method of implementation of waste is, again, the recycling protocol of the operating rooms. And of course, it's put in place by your independent organizations. The result of that, when it's truly a multidisciplinary approach, can have very positive results. As far as a reduction of 11.56 percent, which is great in CO2 emissions, and also up to 13.47 reduction in decreased waste disposable costs. I think overall we can conclude and come to the fact that when we all work together and look at the waste and what we're using, what we're not using from a multidisciplinary standpoint, that means from the surgical tech, from the anesthesia personnel, from the surgeon, also from the housekeeping. We call ours room support. Some of them are called patient care assistants. They may have a better outlook as well on how the organization can achieve and sustain the carbon footprint. The main thing also is to have buy-in by your executive team, because we already know for cost effectiveness and stewardship, the C-suite has to be on board and very supportive. Okay, what happened here? Okay, another question. Let's see if it comes up this time with the Menti. Okay, does the US or Europe have the highest health costs due to carbon emissions footprint? If you're able to type your information in the box, that would be great. And hopefully, it looks like it's 7 participants. Hopefully it will populate. If not, we can wait till the end of the presentation and talk about it. Okay. Okay, I have a USA. All right, anyone else? There's 2 respondents. All right, 4 more. It's a learning process. It's a learning opportunity. I think everyone pretty much knows the answer to this. So those of you who said the US, you are correct. US health cost, air pollution from burning fossil fuels, a primary driver of carbon footprints, results in approximately 107,000 premature births and 820 billion in annual healthcare cost in the United States. I'm going to read that last part again. Results in approximately 107,000 premature deaths and 820 billion in annual health cost in the United States. That is a lot. And that is simply from air pollution and burning fossil fuels. So again, we think about the waste at work that's burned in the incinerators at work. Are we placing the waste in the appropriate receptacles? Are we adding an abundance of waste that should not be there? Because when we do, you're adding to the burning, which goes into the atmosphere, which is why I stated earlier, we're not only creating this for the operating room environment and for healthcare just in the operating room, but collectively for the now and for the future. Now, the European health sector emissions in European Union, the health sector's greenhouse gas emissions are estimated to cost 25.6 billion euros in health-related economic damages. Now, it's not as vast as the United States, but you can see there is still some contributing factors and costs related to that. And with the climate that we're in regardless of where we are, we're all on the same page. I think we are anyway, globally, as far as healthcare and the cost associated with it. We have to be very cost cognizant. We have to be conscientious of cost as it relates to healthcare, because it's vastly changing. It constantly changes, and we have to always look at programmatic ways to remain good financial stewards. Global future impact: climate change could lead to excess health costs in low and middle income countries, at least of 21 trillion by 2020, and that's in the US. So we talk about emissions, we talk about global climate, global warming. I think if we look outside and look around us somewhere, wherever we are, we can see the impacts of global changes and of climate change. There was a time, I remember, and I'm about to date myself, back in the 90s when I was still in high school. One of our vice president mentioned the effects that climate change could have on our environment. And I don't think at the time, I know as a teenager, I didn't take it seriously. Fast forward to now as a seasoned adult, I can see the effects of what not being a good steward of fossil fuel burning and emissions, what it has done to to the world, actually, not to just the United States. So integrated sustainable strategies for practice modifications, reusable instruments and gowns. Now, again, this is whatever works for your organization. Some organizations like to go, like I said, have a mixed method where some things are reusable and some things are disposable. It just depends on what works for your organization. So reusable instruments is something that is very much widely practiced. Instead of buying and constantly re-sterilizing items, because it cuts down on infection control a lot, we want to go to the disposable route. But is it always economically savvy and financial savvy and sound? So the reusable, like the graspers that you see in the picture, those are sometimes, a lot of times, sent out to third-party vendors in hopes that the sterilization process has been appropriately met. But the reusables helps curtail the cost of the disposable items. And again, not every item is going to be reusable. Now, some physicians may not like the reusable items, and as good stewards, as circulators, and as organizations, we should let physicians know when they are using reusable instruments and not a brand new item or disposable, because they have a right to know in the event something happens, it doesn't work properly, as sometimes they don't. That way, they can let the patient know if there's an unfavorable outcome. The same with gowns. Our gowns are disposable, whereas to not long ago, a couple of years ago, they were still the reusable ones. But in a cost comparison, our organization chose to go to the disposable route. Energy efficient HVAC and lighting, that goes to ASHRAE, where they're looking at their ventilation systems and what lighting is more effective and emits the least amount of power. Also, anesthetic gas alternatives. I know later on in my presentation, I'll just talk a little bit more about that. And recycling and waste segregation. So again, with the recycling and waste segregation, making sure the appropriate disposable item is in the appropriate bin. I know in our facility, we have we partner with environmental services, and we have waste audits, because in California, not everywhere in the United States, but just in California, we have the DA will go around to different hospitals, follow the waste trucks to the landfills to make sure the appropriate waste is in the appropriate receptacles and being discarded appropriately. And if not, the hospital will get fined. And so that's very costly. It's extremely costly. So what we do is we partner with our environmental leadership, environmental services leadership, and we have rounds, we have audits to make sure, they're quarterly audits to make sure everyone is disposing the waste in the appropriate receptacles, because that has a lot to do with how they are disposed of. Are they going to the incinerator? Are they being disposed of in a different method, just in the landfill? Um, and it also depends on what's being released, because everything shouldn't go to in the incinerator. One thing I know we had some issues with is individuals putting from the post lavage, the batteries, they would just put them in the trash instead of separating them, putting them in the appropriate receptacles, and they ended up in the incinerator. And so what happened? We had an explosion and fire because the waste was not put in the proper bin. So there's a lot involved with that. And I know we get into the go, go, go and the hustle and bustle of being in the operating room, but we have to always remain cognizant of everything totally, holistically and collectively, not just focus on one aspect of it, but totally. As far as the anesthetic gas alternatives, we work with our anesthesia providers. We have scavenger systems. In our time out, we state whether or not it is a closed system. That way, there's no gas that's being released into, for various reasons, there's no gas that's being released into the OR environment for fire safety, and also that no one is breathing in. So global headways and taking the charge. And I'm going to read this off my notes because I want to be very clear about this. This is some very great information. So the United Kingdom Health Services has a net zero initiative which aims to control hospital emissions by 2040, and emissions influenced by supply chains by 2045. I thought that was very great that the initiative is already in place from a global standpoint, and it stages it in two different levels. The focus is on the hospital side, and then the second focus is on the supply chain side. And I'll get into supply chain a little bit further on. Australia's Green Theatre integrates recycled IV bags and O2 tubing into garden hose and floor coverings. That's a great way of recycling back into the environment. While the Australian and New Zealand College of Anesthetics aim to minimize volatile gases such as desflurane in their approach. Kaiser Permanente has a program in the United States to monitor the waste. They were, and it's public knowledge, they were one of the hospitals that were cited for where the DA followed, and they were cited because there was inappropriate waste being taken to the landfill that should not have been there. And so they have their strategies and methods in place to prevent further actions being taken against them, and to just create a sound and structured process to prevent isolated incidences like that from happening again. So one thing that it is really passionate to me, and what we always have to remember, is the low and middle income. We have to remember innovations for them and the sterilization and recycling process that helps demonstrate the scalability and sustainability efforts for the overall global effect. Okay, let's see. not sure. Give me just a second to see why it's not, the slide is not advancing. See if I can pick it back up where I left off. Okay, let's see if this will work. Okay, leadership and strategy development. So the role of the perioperative leaders is going to always be advocacy, vendor partnerships and supply chain, and also global framework um, from the from the United Nations Sustainable Developmental Goals and WHO. So one thing I want to go back to is the vendor partnerships and supply chain. As healthcare leaders, and this does not just mean nurses and doctors. This also, again, includes the surgical techs and your ancillary support. We need to be at the table with the supply chain. We need to have a voice, and we need to be very active and proactive in the items that we need. Now, a lot of time vendors like to push their products. However, as the experts at the bedside, we should have the voice to be able to speak up to say what is needed and what is not needed from a financial standpoint, from a patient safety standpoint, and what actually works for the overall operations of your department and organization. And so you think about custom packs. Is it more you do a cost analysis, you do a breakdown in cost, and you look at what you're using versus what can be in a custom pack? With some of the physicians, you look at, I'm thinking about for as the robotics, you look at what physicians can, how can you standardize instrumentation trays? Now, I know each physician has their own nuances of how they want to do things in their own personal preferences, but from a strong financial and foundational perspective, what can you create as a standard pack? What can you standardize as an instrument tray that everyone uses? Everyone would have to be on board with that. You would really have to have a strong physician champion for that. And everyone would have to truly be on the same page and have the same common goal in mind, because that can be a lot. It could a hard topic. It can be one of those difficult or hard conversations. However, in the essence of patient safety, because of sustainability, those conversations have to be had. So you want to always get with your vendor partners and have a voice at the table for what's used, not necessarily the director, not necessarily the C-suite, but the experts at the bedside, which would be your immediate circulator and your surgical tech when it comes to standardizing packs and engaging and involving them in sustainable methods. You want to also, leaders and nurses, you all have a voice as well at this, create policies. You cannot hold anyone accountable. We can know what to do and what not to do, but you want to always make sure your policies mimic what you are trying to implement. And when you're writing policies or creating policies, understand the difference between, because it took me initially in my I want to say younger years because I don't want to date myself again. In my previous years as a nurse early on, I didn't know the difference between the policies and the procedures, even though it's all contained. Your procedure method is one thing, but when you write your policies, you want to make sure you're highlighting what the focus is and what the framework that you're trying to implement. So if it's sustainable of making sure certain items are in certain receptacles, have it in policy, because I can tell you firsthand, if it's not in a policy, staff can push back on that. And so in order for anything for you to gain traction and for it to be sustainable in practice, you want to make sure your policies reflect what your common goal or what your outcome is going to be. All right, I have another question, some more interaction. How can nurses advocate for change? I think I just mentioned a couple of them, but there are a lot of other ways nurses can advocate for change. I have 9 participants and no responses. So I am going to keep my fingers crossed and hope that we can have more dialogue about this at the end of the presentation during questions, because nurses definitely, there you go, leadership, okay. Absolutely. Evidence-based practice. Okay. What about grassroots? What about advocating on a legislative level? I think about smoke evacuation. In the United States, it is not a common practice. It's not a bill in every state. And so, from a grassroots standpoint, nurses have a strong voice to advocate for that as well. And I love that stewardship and taking the lead. I think nurses need to understand and always know that your voice counts, it matters. And I think when you're creating teams, when I say you, I mean us, we collectively as healthcare providers, that we have to work collectively and support one another, especially for strategies of this level. Serve on advisory boards. Absolutely. Absolutely. Shared governance. I love it. Yes. Yes, yes, yes. I'd love to hear your shared governance approaches. I come from an organization. My former organization is now a 6-time magnet designee. And so a lot of my foundation as a nurse was rooted in shared governance. And it goes a long way as far as patient advocacy. Call to action, commitment to future integrations. Or teams as advocates, just like I just talked about, speaking up. Do not ever think your voice has to be silent. Always speak up when it involves patients, when it involves your team members, and when it involves yourself. I tell everyone, make sure you take a personal commitment in your professional growth and not necessarily look to your employer to invest in you. You invest in yourself. And by doing that, you'll become more inclined to advocate. It keeps you abreast as to what's going on when you get involved in your professional organizations, not only your professional organizations, but other organizations associated with your field. It could be a medical organization. It could be advocating with the anesthesia providers, but knowing and being able to advocate for one another goes a long way. Nurses leading change. One thing nurses need to always remember is that, again, you lead the charge, which means you lead the change. And so taking a stance for greenhouse, for sustainable ORs, for emissions control in the operating room, please speak up, become familiar with those areas and any area that contributes to increased emissions in healthcare settings, whether it's in the operating room, whether it is in other parts of the hospital, or just in healthcare in general. Know what those items are and advocate. Also, the main thing is going to always be, again, tied to the financial stewardship. So become inclined of the cost. Do cost comparisons on your own in a shared governance aspect. If you're looking at cost comparisons with reusable versus disposable, From a shared governance approach, you can do a little game at one of your meetings to show the cost variation and difference between the two, and that can help drive change in the OR environment. And it could also lead to substantial changes throughout the organization. It can start with you, but once the administration sees the financial difference that the OR can make, it'll translate over to other services as well. So my conclusion is planting the roots of change. And that means a sustainable surgery is a global responsibility. Safe surgery should always be green surgery or a mixture thereof. And it's very important that we stick to that we maintain rooted in that for these beautiful little people on this screen. Because again, it does not only have an effect of today, it also has an even more profound effect for the future. These are my references. Any questions for me? I love questions.
Thank you so much, Dr. Nikki, for this impactful section. Thank you so much for creating your time out of no time to, have this section for every operating room professional. We are so grateful. Thank you so much, Ma. So this is time for questions and answer. Please, if you have any question, please, can you use the chat box, type in your questions, or if you want to raise your hand, I can call you up for your question. Okay? Do you have any question? Please type in inside the chat box. Okay? Dr. Nikki, as you wait for the question, this question comes to my mind. Please, is there any way that we can embed this sustainability into surgical education and professional training curriculum, especially for the low-income countries?
Absolutely. I think you brought up a great point, education. It starts with education in the beginning. I think if you incorporate it in a orientation plan for onboarding of new employees, as well as incorporating it in services in established operating rooms. I think the first thing is having the buy-in with administration, and then creating some type of, whether it be a pathways or modules on the computer where they have to do annually. And also, my favorite is return demonstration. Maybe they can do incorporate that type of education into the OR environment and create a curriculum per se in the from the orientation standpoint for new hires.
Okay.
Did that answer your question?
Yes, thank you so much. Because most of the time in the education system, they generalize, how to waste disposal. But if they can, specify and about the operating room, it will help a lot. Thank you so much.
Yeah, absolutely. And another thing is having signs. What we found helpful, now, even though they have the signs up, staff still put the items in the wrong receptacle. However, it's an education opportunity. And so there are signs that states what goes in which receptacle. And again, if there is a environmental environmental services department, they could always do an in-service for the operating room as well, since they're the experts in that area. At least in our facility, they're the experts in that area. So they would come and do the in-services for our team, as well as in other departments in the hospital. That way, if staff had questions or needed further clarification, they could ask the experts versus us not being able to answer all of those questions. You have the experts in that area at your table, in your environment, and in your department, providing that education for the team. and also giving them little no-do shares, little refer to pamphlets or items that they can keep handy to refer back to as well.
Okay. Thank you so much. Thank you.
You're
Okay.
welcome.
Thank you. Okay, another question I have is, what if in a surgical team and you find out that the institutional leadership is not yet supportive? How do you go on with this initiative?
So I will take it all the way back. I'll take it back to, it's a couple of things I can take it back to, the sharps, but I'm going to take it to the most recent thing, which is our smoke evacuation system. So smoke evacuation is not anything new. I've been in the OR since 96 and it was talked about then, and evidence-based tracks it all the way back to the 60s, 70s, 80s. Whether or not the administration is on board doesn't mean you can't start the change at the bedside. All you can do is advocate for the change, make the change in your practice setting, come with literature, come with literature to show administration, show them the financial aspects and the advantages of those strategies. One thing about administration, they're going to always fall back to cost. Unfortunately, everything is going to relate back to cost. So if you, as in your team, because you can't do it by yourself, it'll have to be a concerted effort of the entire surgical team, because it's going to start with you. You're at the bedside with the patient. We know what the effects of surgical smoke is. We know what those effects are. We know that it causes harm. We know that anything the patient has is aerosolized and emitted into the atmosphere. We know our mask does not filter enough of the plume because the particles are small enough to go through. So anything that patient has, we're breathing it in. Whatever is in the atmosphere, it stays in the room for approximately 20 minutes after. So not only are we at risk, but the other patient coming in is at risk as well. So knowing all of those evidence-based practice measures to take and knowing what happens and the dangers of surgical smoke, we as a team, regardless of what our leaders supported until we obtained the financial aspect of that, there were things we did in the operating room. Okay, instead of giving our physicians the choice, our medical director stated that we were going to use, because like I said, we've always had smoke evacuation devices in the OR. They were just optional. And so when you have a strong physician champion like we had, they made it a requirement that we use them on certain procedures. So we didn't start big, we started little with certain procedures like the total joints, with open belly procedures, any procedure that emitted a lot of smoke. We started with that. And so once other organizations started gaining traction and started becoming more ingrained and becoming more everyone adopting the process, administration got wind of it. They started asking about the financial impact of it. And then that's when the vendors became on board. That's when the experts sat at the table. And then that's when the conversation took place. So whether administration is on board or not, if you have a strong surgical team and a strong physician voice, then you can push for change and allow administration to get on board once they understand the financial implication as well as the patient safety implication that's attached to that. I'm not saying it's going to be easy. What I am saying is that you build your relationships with your physicians, you build the relationships with your team, and that way that that team is there, that connectiveness is there, and that voice is there. And you also want to make sure you present it to the C-suite as far as they understand. Now, your CFO, you're going to always have to explain it, and you're going to have to always present the financial aspect. But your CNO or your chief nurse officer or exec, they should be on board, okay, with patient safety as far as the president.
Yes. Thank you so much. Thank you.
You're
Okay,
so very welcome.
let me read out the question from the chat box from Annie Maria. The question is, how dangerous it is to operating without a smoke evacuation to the personal and environment?
Is very dangerous for the personnel because and for the environment, because if you don't have good HVAC systems, even though there are certain filtrations are the OR should have a certain amount of air exchanges, the HVAC ventilation system should be a high quality HVAC system. I'm not an expert in what that high quality looks like. However, I do know it plays a part in that. As far as the personnel, is very dangerous because again, our surgical masks do not filter all of those particles. They do not. And anything that patient has, it's aerosolized. Now, the research does state that surgical plume has byproducts of CO2, formaldehyde, glutaraldehyde, and carcinogens. That's evidence-based practice. And so we're breathing that in. And so not only for one case, you think about how many cases some people have back to back throughout the day. And so it's very dangerous, extremely dangerous. And I would encourage you to just look up some of the information on the internet, not just don't go to Chat GPT, don't do that one, because we want to make sure our evidence is factual. So go to some of the evidence-based articles. You can go to Google Scholar. That way you will have the professional journals that cite that. AORN, which is the Association of Operating Room Nurses, has a lot on surgical smoke evacuation. They have toolkits, they have a lot of tools and resources. It's a lot of information out there. If you want to connect with me offline, I would love to continue the conversation and provide you with any information that I can to help you in that area.
Okay, thank you so much. The next question from the chat box. The question is, we've seen a lot of progress in AI and machine learning recently. Do you see a future where AI helps us manage our surgical preference cards more accurately to prevent the opening of unused, wasted, sterile items?
I do. And one thing I have to say about AI, and I'm so glad you brought it up. AI is, if you don't understand it, can be a little scary, a little intimidating. However, it's how you utilize it. And just like whoever asked that question, thank you. There are a lot of programs out there now where AI is assisting with preference cards. Preference cards are a nuance. They can be very challenging. You can think you have them perfect, and long and behold, the next case is not anything like the first case, and you just did it, but the cards are not accurate. And so there are products out there to assist with that. Now, one thing about AI in healthcare, I'm not going to say it's new because it has always been around at some fragment. However, the way it is being introduced now, they're very proud of their prices and their product, which means it's very costly. However, what I would say is get with your nurse. If you have a VP of surgical services, or if that's your COO or CNO, get with them, have a conversation, and just see what's out there. It's more than one company, so they can be very competitive. And then that's when you can negotiate price better when it's more companies out there with the same product versus just one company having it. But I do know AI is being utilized to perfect, per se, preference cards. I do know that.
Yeah,
And what was the
thank you.
second part? What was the second part about the AI, the preference cards, and what else?
About more accurate to prevent the opening of unused, wasted, sterile
products.
items.
There is another product. I went to a conference last weekend, and there is a company. It's called Pegasus. and they work very closely with sterile processing. And there's a way the gentleman explained it, that they can scan the cart in some kind of way. The AI can tell what instruments should be open and what not be open. And so I thought that was a very great tool to use as far as sustainability, when AI can go in and look at what's being opened unnecessarily as far as instrumentation, and say whether or not too many instrument trays, because each time we don't really think about sterilization of trays creating to emissions, but it does, because you're continuing to re-sterilize. So the more you re-sterilize, it adds to that emissions as well. And so the amount, if you can decrease the amount of sterilization by only opening what you need, it will help and contribute to that. And so that was last weekend was the first time that I had ever witnessed or heard about AI being able to determine that. As far as the supplies, I'm not sure, but I'm more than certain that there's some type of AI capability out there also to help with that. But I'll take it back further. Even though AI is a great tool, there used to be, and there's hopefully there's still a time where we write things down in a little, I used to have a little black book. And so I would write down what to open, what to not open, what to hold, what to have in the room, according to the physician. Things have changed over the years, but certain elements of basic elements, I think, should remain the same. So I said that to say this. I don't want us to get comfortable or dependent solely upon AI, even though it's a great adjunct. It's a great adjunct to surgical services. But also remember some of those core basic fundamentals that we use for the seasoned staff, of writing things down when you can, looking over cases before you go into the case. And that way you can think about, okay, this is what I need to use if you reference back to something that you wrote down versus relying on your memory.
Okay, thank you so much. I still have more questions. I'll take about one or two because of our time. The next question I have here is, what metrics should hospitals prioritize when measuring the carbon footprint of the OR? And how do we avoid greenwashing?
How do we avoid, I'm sorry, the last question, how do we avoid?
How do we avoid greenwashing? Greenwashing.
How do we avoid brainwashing?
Green.
Green.
Yes, greenwashing.
So I will say this to the metrics. So, and I'll take it back to your audits, and I'll take it back to accountability. I'll take it back to the policies. You can measure by your audits. You can measure the completion of, let me just see, with the receptacles. Is the compliance, are they putting the disposables in the right receptacles? What does that audit look like? Those are your metrics for that. It's not truly a KPI, but it is a metrics that you can measure to see if compliance is there. By doing those audits. With smoke evacuation, you can have a audit tool. You can first create a gap analysis, do a gap analysis to see what do you have, what's working, what is not working, put things into place, and then look at your compliance level over that. That's how you can measure that. And I have a gap analysis sheet that I did not put in the presentation for smoke evacuation, but you can always, I have my contact information at the end of this, and I'll email it to you. That last part of that question, I don't know. I guess just remaining intentional in what you're doing to make sure we stay sustained and on the right track of being green. looking at other avenues, because again, things are going to go back and forth with organizations because they're going to look at what's more financially feasible for them, but being able to speak up to that, of what that looks like and what's best, for everybody in the operating room. Now, sometimes it's not going to have the effect that you think, but at least if you have the evidence base to back it up, then you should, it should be more advantageous for you to use that and to be able to speak on it for the sustainability of whatever is in place or whatever those suggestions are.
Okay. Thank you so much. Okay, please, the last question we're going to ask for today from Cherry. The question is, what are the strategies you've used for overcoming surgeon resistance when transitioning from single-use instruments to sterilized reusables?
So every surgeon is not going to always be on board. They're not. And so we have a strong surgeon champion for surgical services and a strong medical director over all of the physicians. And so when you look at the cost and you look at the rationale and the reason, it has to support what their claims are. And there has to be repetitious claims by different surgeons of the same outcome, or the instrument not working. So I'll say about the shears that we use for our harmonic scalpel. They are reusable. They're not reusable, I'm sorry, they're recycled. And some doctors like them, some of them don't. Some of them a couple of them complain about the same thing. And so with our compliance with supply chain, we have a certain percentage that we have to remain compliant in. It's not 100%, it's 80%. And so 80% we have to remain compliant with the reusable, 20% we don't. So if we have a small percentage of physicians that want to continue to use the disposables, we have to remain within that category and that realm of that 20%. We can't go outside of that. We don't have the latitude to tell a physician, this is what you're going to use and you have to use that. We're not there yet. However, some facilities let their physicians know, no, this is what we have and this is what you have to use. That's something that staff should not be in the middle of. That's between administration and the physicians of how it's presented. But if you have a strong physician champion that understands the why the organization is doing it, they have those conversations at meetings prior to the mandate being implemented, it makes a big difference. But one thing about surgeons, you can't implement something and not have them at the table to let them know ahead of time and expect for them to be okay with it, because ultimately they are the ones doing the surgery. And so they need to know the whys. They need to know what those alternatives are that they will be using. Great relationships. If you start with great relationships, information, and education, the resistance, I'm not going to say it won't be there, but it should be less.
Okay. Thank you so much. Thank you so much for answering all the questions.
Absolutely.
Thank you so much. Thank you. I'll go on to hand over the mic to my colleague to give the closing remark. Thank you.
Thank you.
Good evening, everyone. Could you please confirm if I'm audible? All right, thank you so much. On behalf of the Operating Room Global, I would like to sincerely thank our speaker for her valuable insights and our participants for joining us across different countries, different time zones, and professional backgrounds. We recognize that many of you are participating despite your busy clinical schedules, varying internet accesses, and language differences. We truly appreciate your commitment to learning and to improve surgical and perioperative care in your local settings. Please feel free to share our key lessons from today's sessions with your teams, institutions, and professional networks as part of strengthening safe and effective practice globally. We encourage you to stay connected with TORG through our upcoming webinars, training programs, and research activities, which are published on our website and across our social platforms. To receive your TOG accredited certificates, please note the following. Very immediately after the session, the evaluation certification form, they'll be open on your browser device. Please take a note that it will be open only for 24 hours. Certificates, they'll be issued within 5 to 7 working days after a successful submission. Evaluation is mandatory for accreditation, and certificates are linked to your TOG membership ID. Once again, thank you so much for being a part of TOG's global community. We wish you a very safe, productive day or an evening ahead, wherever you're joining from. Thank you once again for joining us, and we look forward to support your continued professional and development with the Operating Room Global. Thank you so much.
Have a good rest of your day and evening, everyone, and thank you again.
Thank you.